Thank you very much, Chris, and thank you to PK and Dirk for the kind invitation. I'm presenting on behalf also of Mark Broziers from Belgium. I think that we still consider bypass as the golden standard, and here is a list of all the publications that have been presented. And bypass primary patency at 12 months is reported to be as high as 78%. However, if we compare these data, and especially the primary patency definition of endovascular therapy with the definition that is used in surgical therapy, there is a lot of difference. I think in endovascular everybody agrees that we are looking for binary restenosis with a PSV of more than 2.4. However, in surgical procedures, patency is defined as any kind of flow that is present, and that might even be a restenosis of 90%. These are some data from Mark Broziers, where they looked at primary patency definition according to the endovascular rules and the surgical rules. And here you can see that a 100% surgical primary patency translates into an 89% endovascularly defined primary patency. So there is a significant difference. What do we know about the treatment of long lesions, TASC C and D, with drug-eluting stents? There are several studies out there, again from the group from Belgium, looking at 135 lesions with a significant lesion length, as you can see here. All de novo lesions with a high percentage of total occlusions. And here you can see on the left-hand panel the primary patency, that is 77.6%, and the freedom from TLR being 85.4%. Even more data came from all the trials in Japan. This is the ZEPHYR trial, looking at almost 700 patients and more than 800 lesions. Again, a very long lesion length, and lesions were assessed also, apart from angiography, also with IVUS. 1-year restenosis rates were 15% in cases with none of the risk factors that were identified, and 50% in those with more than 2 risk factors. And here you can see the difference in the restenosis and male between the two groups. The ZILVERPASS post-marketing study, also in Japan, in almost 1,000 patients. Mean lesion length, again, around 15 centimeters. Actually, more than 15 centimeter lesions were seen in 42% of cases, and even almost 30% of cases had lesions longer than 20 centimeters. And you can see here that the primary patency on the right-hand side is still 86.4% at 1 year, and the freedom from TLR is 91.0%. So these are good results with this specific stent. In order to compare this with the bypass, they looked at they developed the ZILVERPASS study that's intended to evaluate the performance of the Cook ZILVER-PTX paclitaxel-eluting stent compared to bypass surgery using the same kind of definitions. Randomization was performed in 220 patients, 4 countries, 13 clinical centers. This is the timeline. At this moment, the enrollment is complete, and I will give you an overview of the data thus far. Inclusion criteria were patients presenting with lifestyle-limiting claudication, rest pain, or minor tissue loss, stenotic or occlusive de novo lesions, and a total target lesion of at least 150 millimeters. These were the exclusion criteria: any previous surgery, perioperative unsuccessful ipsilateral percutaneous vascular procedure to treat the inflow disease, any additional intervention that was planned, or major distal amputation in the study or non-study limb. Definition of the primary endpoints for both groups was the same, so looking at binary restenosis or occlusion within the treated lesions and target lesion revascularization or re-intervention. The demographics were more or less similar, except for the fact that the bypass group had some more CLI patients. It also had more patients with hypertension, obesity, and hypercholesterolemia. The lesion characteristics were more or less the same. There were slightly more occlusions in the bypass group, and the lesion length was very similar. Here you can see the procedural characteristics. Hospital stay was significantly lower in the ZILVER-PTX group, and also the procedural time was much lower. Looking at the primary patency at 12 months, you can see that there is a difference in favor of ZILVER-PTX, and also the freedom from TLR at 12 months showed a benefit for the ZILVER-PTX arm. Secondary patency was the same, indicating that you can still treat these patients also properly afterwards. Complication rates were lower in the ZILVER-PTX group, and also the primary patency at 24 months that is not available yet for the entire cohort, as you can see here, was better, or was slightly better for the ZILVER-PTX as compared to the bypass, and also the freedom from TLR better again for the ZILVER-PTX as compared to bypass. Just to put this in perspective, this is an old paper looking at bypass versus PTA in a decision analysis. Type C lesions were evaluated with some hypothetical cohorts, and they looked at quality adjusted life years. And actually, in order to get the same result, you don't need that much of a patency with endovascular therapy as compared to saphenous vein bypass grafting. To conclude, ZILVER-PTX is obtaining outstanding primary patency rates, confirming the data that we have already from registries. It is likely that the prosthetic bypass results are not as good as always thought, especially when you use the same assessment criteria, and preliminary results show at least a non-inferiority of the ZILVER-PTX versus prosthetic bypass surgery above the knee with similar patency results and less complications. Thank you.